this is all about you. This is not about me at all. So use this time. I'm here. I was here yesterday. I'm here whole day today. For anything that you can get out of me and others, of course. But again, this is not to impress you with anything scientific, with anything medical. When I look at what I do, when I hear with some embarrassment, what Robin is saying about me, this is really not about that at all. The only value that I have is the value I can bring to the lives of others. This is your kids, your loved ones, you. That is the only metric. And the fact that I went to school for 30 years and I studied a lot of things, that's sort of assisting in that. But it's not the metric. The metric truly is when I have somebody who just came to me over there and mentioned the name of a patient that does not have Dyskeratosis congenita at all. She had severe plastic anemia. And without being public about this, I know for a fact that if we have not done the things the way we have done it, she would not be here today. So my satisfaction from everything I do comes not from the papers, not from the grants, not from the titles, but comes from seeing your kids, somebody else, 2 years after transplant, 3 years after transplant, 5 years after transplant, 10 years after transplant, and seeing that they have forgotten altogether that they actually had some disease. Well, not entirely, but yes. So the bottom line is that you need to interrupt me here during these, half an hour, 45 minutes. You need to see how I can be a partner to you. How can we make the partnership between us meaningful, helpful, life-changing? Good? All right. So, I don't have the clicker. Am I supposed to have a clicker? I think so. So I want to tell you that I would be, or somebody in my position 100 years ago, may be as, dedicated, reasonably smart, reasonably lucky that he or she went to the right schools and so forth, reasonably compassionate about what they do, but entirely helpless and entirely useless in a way to you without science. Okay? So science has changed what medicine is about. So it's always good. The clicker is good, but it doesn't work. Okay? Oh, maybe a magic touch. No? It's always, I like unexpected. In everything that I do, unexpected is the best thing that happens. It's like in, the Dory movie, right? The best thing in life happened by chance, like this. So I don't need slides. I have done talks, with 0 slides. If you imagine yourselves, or myself, or my loved ones, 100 years ago, these people were exactly the same as we are, right? They died of things that we don't even think about. These are the things your kids get vaccinated against. That was a common thing to die of. They have seen a huge number of their family members, and half of their children die of things that we don't even know that are a problem, okay? And the only reason that happened was science. It has nothing, and I am representing medicine here, it has nothing to do with medicine. Medicine, it is that you walk in the office and you do all you can, with somebody you have in front of you. But you cannot do much unless you understand the beginnings of the disease. Unless you understand it, you cannot fix it, right? And the reason why in medicine we know how to do things is not because of people who were in medicine, but people who were in science, and then these fields merged. Make sense? All right, so for example, Dyskeratosis congenita, the fact that this is even a genetic disorder, that we even know what genetic disorder is a very recent thing. You know, the April 25th, 1953, remember that? April 25th, 1953. Okay, that's the paper that for the first time said that there is something like this DNA, this recipe, this blueprint for cells, that they know what to do, where to go, how to react. That's the master plan for every cell. That's very, you know, it's about 10 years before I was born. This is not very far in the history, right? That's how we went and were able to go to the bottom of the problem and identify genetic causes of number of conditions like bone marrow failures, like Dyskeratosis congenitas, but also others, like cancers, some predisposition to other very, very common disorders like diabetes, like myocardial infarction. The whole wealth of understanding comes from science. So that's why I keep over and over and over repeating that we need to keep these things together. So like the fact that I have taken the directorship of the Stem Cell Institute and I have 30 people in the lab is a direct continuum to my clinical practice. I personally think we make a huge disservice to the society that we send people to medical school, give them MD, and then somebody to grad school, give them a different letters after their name, and then these are apart. I can tell you that the reason why, oh, you're so kind, thank you so much, I think that I get my grants funded is because I actually know what the sick people in clinic look like. And I know the diseases. And the fact, I'm almost certain, with no arrogance, you know, my ego is not a part of this today. I'm just a tool of the schools I went to, of, as I said, of being lucky to be reasonably healthy, to be at reasonably good, you know, schools and whatever, you know, to pick up on this, you know, knowledge. So I think these things are linked and should be linked and, you know, should be connected together. So this is a stem cell. Stem cell is not like a blob of something. You know, this is a very dynamic thing. You know, it has different, you know, communication vessels. You know, it has a space, you know, that it occupies. It's not two-dimensional. It's a three-dimensional thing. And it has a unique capacity that it gives rise to multiple different cells. And we all have stem cells. And if you don't have stem cells, that's what, you know, some aged individuals experience, that they cannot renew their organs. So we renew our organs all the time. You know, it is something that we don't really, you know, pay much attention to unless there is a problem. But in fact, this is the basis of all health. And if you are in the business that we all are in restoration of health when disease occurs. My work predominantly is in blood-forming stem cells. So they are called hematopoietic, or hematopoiesis is the making of the blood. And in broad groups, we call one part myeloid and one part lymphoid. Just remember these names for a little bit because they're going to become relevant. And the cells that we can get, and they live, these stem cells, in the bone marrow, they are stacked next to each other, which is again another important, frequently forgotten thing. They talk to each other. They get their information about who they are from their neighbors. So they cannot be really isolated as we draw them on the pictures. But for simplicity, it helps, right? You know, you have the bone. The bone is occupied by the stem cells, and the progeny cells, the daughter cells, would be the red blood cells that carry oxygen around the body, the white blood cells that fight infections, and platelets that clot blood. All these things incredibly important. So how many cells you think that a healthy individual has to make every single day of these guys to live? 100, 1,000, 10,000. Very good. You get a prize. 10,000. Is that right? Yeah, it is. That was a total guess. That's good. That's even better, actually. So when I think about blood and about hematopoiesis and stem cells, I think about a tree. The tree that is beautiful green, all the leaves there, their stem cells are down here, and as the stem cells grow and multiply, they differentiate, they give rise to some leaves that are red blood cells, some leaves that are white blood cells, some leaves that are platelets, and again, it's like a tree. It's a dynamic unit that is responsive to its environment and lives not in an isolation. The whole field of bone marrow transplantation happened entirely by chance. This is humbling. Many things that I do are humbling. And the older I get, the more I appreciate the wealth of knowledge that we inherited from others and how attentive they were to some of the things that were entirely unexpected. Because as I look at science, you have two things that come to science. One is knowledge. Knowledge is important. Knowledge is what we know, obviously. But exercising knowledge, you know, the major task, I think, is that it has to have some value for people that are alive. It seems trivial, but if you look at some of the grants that I review, it is not so much. You know, many people like to tinker. Nothing against tinkering, but knowledge is really a static thing in a way. What really is important and what really drives discovery and advance and future of medicine and other fields is not the knowledge, it's imagination, it's ability to look beyond what's known. And one of the people that started my field was, he's not on the picture, this is somebody else, is Peter Medawar. Peter Medawar was a surgeon in London during the Battle of Britain, when the planes were coming from the continent and bombing London. And Peter Medawar was, as everybody there, frightened. And as a physician, he was motivated to help somehow the ones that were able to come back from the air fights. And there were few, but those that did come back frequently came with very bad burns. And these burns were lethal. They were fatal. You know, imagine, this is 1940. 1940 is before we had antibiotics. Yes, you can say, you know, Fleming saw this on the Petri dish in 1927, but really it took a chemistry, you know, of 2 decades, you know, to really get it, you know, in a useful way. So penicillin was still a couple of years away. If you have a burn, you know, you are exposed to a lot of not just pain, but infections as well. So what he wanted to do is to skin graft. I'll get back to the bone marrow transplant, don't worry. Skin graft, you know, these individuals, and he failed. Which is another thing we discussed with Dr. Savage just before this. You have to, if you are any good in what we do, you have to show some strength. You have to show some ability to withstand misfortunes and failures. So the failure in this case was the opening, and the only opening, to what he actually did do, which is he transplanted bone marrow, and only then he was able to show that the skin engrafted. That's pretty remarkable, right? Okay, so then people on this side of the Atlantic, Don Thomas and others, have picked this information up and said, well, maybe the people who have leukemia can be saved by this. Now, again, you have to go back a little bit, you know, to see, you know, how exactly the same people as we are have been faced with leukemia some 50 years ago. 60 years ago. Everybody died. There were no survivors, zero, okay? Adults, kids, everybody. There was nothing, okay? So there was a time to try things, you know, that are not common. Because if you were repeating the same things as everybody else before, which was what? Compassion, maybe transfusion, here and there, that was it. You know, you would end up in exactly the same spot. So the risk, and that relates to the bone marrow transplant even today. That's the part of the decisions that you are facing even today, because you are accepting, on behalf of your loved ones, a high-intensity therapy for high-risk disease. You accept risks that would be unacceptable for somebody who does not have dyskeratosis, or does not have a bone marrow failure with dyskeratosis, or a squamous cell carcinoma. And this is, you know, this is not even unfortunate or unfortunate. This is what it is. These are the realities that these individuals that had leukemia had faced the exact, they knew what's going to happen. So going to the untested bone marrow transplant was something that made sense to them and their physicians. Okay? So Don Thomas and others have done the first transplant, but really every single one of them, and there were hundreds of them, failed. And they failed because, I'm getting back to this again, the science was still not there. The immune groups, that were so important and are still important, as you remember, from some of your transplant, Gabby, Josh, we are looking for the HLA, the human leukocyte antigen groups. And so we are still using this knowledge. And when Don Thomas and his group in Seattle were doing these transplants, they didn't know this. This is incredible. Because it is as if you were transfusing somebody today with red blood cells, not paying any attention to a blood group. Anyway, Bob Good, in my adopted hometown of Minneapolis, was the first one who actually did a successful bone marrow transplant in November of 1968. So you now had an ability to do something in the operating room, in the harvest, and then restore the hematopoiesis of somebody that has either failing one or a leukemic one by transferring the marrow from one individual to another. And I'll get to the gene editing and gene therapy at the very last part of my talk, but it's a part of this process. You probably see by now that how I view this is a dynamic, moving front, that no complacency has place. You have to always push. You have to be able, again, to withstand some not knowing, because if you don't, you will stay exactly where the field is at today. Okay. All right. So how does bone marrow transplant work? So first of all, you need a donor. The donor is something that we have been able to perfect over time because it's literally like a puzzle. You go out and you seek out individuals, that can be they can fit literally in the groove, of somebody else's immune system. And the way we do this is that we look at these human leukocyte antigens. They are on a chromosome 6, and we say, well, do you have a sibling? Some of you, have match sibling transplants in your families. Do you have a sibling that happens to be HLA, human leukocyte antigen, genotypically identical to the child that needs a transplant? And that happens in about 23% of times. So it happens. The larger the family, the more likelihood it is that there is somebody who has this. It's important to say even now that in genetic disorders, you need to make sure that the donor is not affected by the same disease than the one that you want to transplant, right? Some of these individuals may carry the mutation and not yet be symptomatic or not ever be symptomatic. We call it subclinical, but you always have to look. So in somebody with dyskeratosis, we would look for the mutation if it's known, or we would look at the length of the telomeres that Dr. Bertuk discussed with you yesterday. So you have to take these things into account. You can either look in the family or you can look in the about 15 million donors, adults like yourselves, are gathered around the globe in the unrelated donor pool. And they, when I call upon them or my colleagues call upon them, this is somebody that has been on the registry for years or decades, and then they go through the harvest and provide a life-saving product to somebody they don't even know. And sometimes years after, we allow the families to meet, and many times this is these are one of these highlands of life, I think. This is sometimes, very defining for both the recipient and for the donor to meet, these partners over time. So it can be a marrow, it's on the top. It can be what we call peripheral blood stem cell collection, which is basically the same thing, only you use medications that which you actually know, the GCSF, and another one called Plexif that can tell the stem cells to get out of the bone marrow, and then you collect them from the vein in the neck. Or you can use a cord blood. We have about 5 million cord blood units in the world that have been collected after healthy birth, from children, frozen, and we know they work. They work as long as 30 years, being frozen, and you can take them out of the freezer, and if they are matched, you then use them for the transplant. Still good? No questions yet? Okay. I told you, you have my permission to stop me, actually. It's a good thing, I like to be challenged. I like to be, again, helpful. So now I'm moving to the second part of the transplant, which is, again, the blocks that you need. So first block is these biobricks, these cells that you need from the donor. You have to build the new hematopoietic and immune system from something, right? The second is, how do you prepare the recipient, the individual that needs the transplant? And for that, we call a set of immune medications, chemotherapy, and radiation, which collectively we call conditioning. So this conditioning can come in different flavors. And I like this graph because it shows that these terms are not static. They are not defined. They are not one dot. They are actually relative. What I mean by that is there's a group of medications and combinations that can be called non-bioablative. Ablative means that you take out all the bone marrow. That there's no, so non-bioablative means that you actually have very minimal conditioning, and that's used very rarely. That's used in gene therapy trials. The myoablative one we do use in children and adults with leukemia, because then you really, first of all, you cannot afford, just a literally single cell, surviving after the transplant, the leukemic cell. You really have to be very harsh. Otherwise, these cells come back with vengeance. And for those individuals, you accept the higher toxicity that comes with somebody who has leukemia. That is also the reason why I think everyone would agree that in Dyskeratosis congenita, you don't want to wait until there is myelodysplastic syndrome or leukemia if you can. I had just 3 individuals just this year that were with dyskeratosis and diagnosed. When I saw them first, they already had MDS. So sometimes you can't, but if you can, it's better to intervene before that happens, because you can use much less toxic medications that you would have otherwise. And then we are left in the middle with what's called reduced intensity conditioning, which is basically trying to dial it just right. Just hit exactly the right amount of toxicity that you need to withstand to accomplish the goal, which is to have the engraftment done. Now, these 2 slides are connected. This is a slide, and you bear with me. If you understand this, you're going to do better than most of my residents. So there are 3 outcomes of transplant. One outcome is this one. That's a happy outcome. You have stem cells. So the yellow is the donor, and the blue is the recipient. So the yellow here says stem cells, and then these 2 immune cells are B and T cells. This one makes a lot of immune protein, and this is the T cell is one that helps the B cells to make that immune protein, but also is able to remember, some of the antigens, some of the proteins and sugars in the environment that are associated with viruses and bacteria, so that it can respond to it. So if you have a successful grafting or successful transplant, the stem cells from the donor come to the recipient and replace everything inside. All good, right? Successful transplant. If you don't, if the T cells that are the immune cells that I mentioned over here of the recipient, if they are stronger than the graft that's incoming, so that's what happens when you don't give enough of the conditioning. You did not suppress enough of the recipient immune system. Then they will go out and do what they are programmed to do, which is they kill the graft. They kill the stem cells that you so laboriously collected or gave to them, and the transplant fails. We call it graft failure. Still good? All right. And then there is a middle ground, which we call graft versus host disease, which is a sort of trying to reach a balance between the T cells of the donor and the cells, many, many different cells of the recipient. And in that setting, we have to control the graft versus host disease. So if even today and yesterday, people say, oh, so it was so good that she didn't get graft versus host disease. And yeah, that's one way of looking at it. In my book, everybody gets graft versus host reaction. You cannot have it without it. There are so many cells, but the clinical, the part when we actually see it, on their skin, on their liver, in their gut, and so forth, it's about 30% of individuals. And of course, it reflects a more severe reaction, if you will. But most of the acute ones, which is the one that happens in the first several months after transplant, we are able to control with either prophylactic or treatment measures. And then you have the chronic form of that, which is somewhat different condition altogether, which is, as the name implies, which happens later, after transplant, and has to be treated somewhat differently. So I want you to see that these two things, how much conditioning you give and how much graft versus host or host versus graft reactivity you get afterwards are connected together. So you are faced with this conditioning of, as I mentioned before, doing something that is high-risk therapy for a high-risk disease. It is not that we are, somehow complacent about the toxicities we see. Not at all. The opposite. 95% of everything I do on the bone marrow transplant unit is I am taking care of the problems I caused by doing the conditioning. Okay? So of course we are after, and the gene therapy, by the way, is the way, to circumvent some of these problems. It is violent in a way, but this is a type of a controlled, almost altruistic violence, if you will, that you and us accept on behalf of the ultimate goal. Good. Yes. Oh, good. You're so good. You're my hero. Because anybody who asks the question first is a hero.
Is there a chance to get graft versus host use after?
Yes, the chronic, yes. So in medicine, nothing is 100 or 0%. This doesn't happen. So the further away from transplant you are, the less likely to get graft versus host disease. So most everyone who has acute graft versus host disease gets this within first 100 days after transplant. Most everyone who gets chronic graft versus host disease gets it within 3 or 5 years after transplant. Thank you. Her name is Nicole. She's my hero. Okay. Okay. So still good? Did you get this slide? Yeah. Okay. Thank you. It's in your handout, I think, as well. Okay. So now I'm going to spend, because I feel that this is important, to talk about in the almost calm, almost quietude of this room, about some of the things we do. You don't have to remember, all this. It's all in your handout, but just to show you that we are very active, very proactive. In doing what I do, in bone marrow transplant, in intense care medicine, you have to be assertive. You have to do things to prevent things from happening, right? Okay, so for graft versus host disease, we use steroids. That has been on the books for 30 years. And then we do something like, using nature, again, which is another theme that I should have probably, identified earlier. It's much, much better to learn from nature how things are done, like in the hemapoiesis and immune system gets formed, and adopt that than trying to do this by yourself, because we just don't have enough knowledge to understand, all these complicated processes. So, for example, for taking out these T cells that I showed you in the previous slide, what we have done is, we inject human blood to rabbits and horses, and then let them make the antibodies against the T cells. Make sense? All right. So we use them almost as a factory, as a bioreactor, if you will, because they will make a blend of antibodies that is impossible to reconstruct by engineering in the lab. Okay? So that's what we call ATG. Most of you that had transplant had ATG or some form of that. And it comes either from rabbits or from horses. And then we have a number of these drugs, that we are using to limit the amount of immune reaction that occurs with that interaction between the T cells and of the donor and the recipient. The mesenchymal stromal cells I'll get to in the later part of the discussion here today. They are very important. They are the nurturing cell. Remember when I showed you the stem cells at the beginning? Three-dimensional, big thing, right? So, and then I showed you the bone marrow, how these cells are packed together. So the nurturing cells, that are around these hematopoietic stem cells, they are called mesenchymal stromal cells or mesenchymal stem cells. And they have phenomenal capabilities. And one of them is that they are very good for treating and preventing graft-versus-host disease. They modulate, they tell T cells not to go crazy, not to just lift off, and they calm them down. So we have been using them for that purpose as well. Okay, so I said high-risk therapy for high-risk disease. The number one problem we face in transplant is, again, related to what we have done. So we take away all the immune system. Even in somebody who has totally empty marrow with a bone marrow failure, you still have to do it because there are still many, many more immune cells that are very effective. There's nothing in biology more effective than immune reaction, more specific and effective. This is the most specific reaction we know. So you have to do that to take out the immune system so that you can make an environment that is permissive for the graft to take. But by doing that, you take away their ability to fight infections. So infections are the number one problems we still face after the bone marrow transplant. And it takes quite a long period of time to recover the immunity that you need. In some, it takes half a year. Others, it takes 5 years. It may take a long time to rebuild the whole capacity of the immune system. So you have different bacteria and different viruses and fungi occurring after transplant at different times. So we give prophylaxis. Everybody who gets transplant gets medications that control the viruses, fungi, and bacteria from becoming a problem. We have stepped away from the very strict isolation. We used to do this in the 70s and 80s, but we don't anymore because we learned that we are still pretty strict about who comes and visits and so forth, and the hand washing and all these good things. But 80% of the infections that we face come from the body of the individual that is being treated. 20% come from the outside. And the 20% is really what we control. The 80% we cannot really control. This is our way of trying to build a shield, a safety net around somebody who has no immune system. Then we jump on the problem before it becomes a problem. This is no different in the intensive care unit, bone marrow transplant unit, neonatal intensive care unit. We all have the same mindset, which is we look for the first signs of anything fitting into the very beginning of a problem that we already know, is common and happens, and we intervene at that time. So if somebody in my care has a fever, no matter whether they look great and run around, they still get admitted to the hospital, get 48 hours of antibiotics and being watched in the hospital, because we know that if you don't do that, there is going to be significant minority of these individuals. There are some that will be fine, significant minority that will do very, very poorly. And get somebody out of septic shock, as you of course know, is very, very hard. Same for the viruses. We again look at number of viruses. The fallacy here is the classic, and it needs to be repeated. The fact that we are focusing on certain bacteria and viruses and fungi does not mean that we know of all of them. In fact, the opposite is true. Majority of the viruses that are floating around and affect you and the patients that I take care of are either unknown to science, or I have no ways of treating them, identifying them, and they are still a problem. Okay? So this is covering just part of it, but an important one. And we look obviously for any signs that we can find, and fungus. So for me, there are several things that in any professional life you can identify as turning points. And the turning point is never seen at the time when it happens, of course. It happens that you look back, after 10 years and say, that was the time when things change. So Peter Medawar's discovery was a turning point. He didn't know it at the time, but it entirely changed the field of medicine. For me, much, much smaller thing was when I started doing bone marrow failure some 20 years ago, and I had 2 patients in a row that came to me and already had invasive fungal infection. They had aspergillosis, and one survived and one died. I had a huge fight with my colleagues to even transplant that other girl at the time because they thought it was futile to do that. And anyway, at the end, she was very sick. She had a horrible time after transplant. But I went to her college graduation. She's doing master's program in social work, in Duluth, in Upper Minnesota, right? And that's again, you sort of look back at this and say, well, maybe, I did something that mattered. Anyway, since that time, the turning point, for me was that imprinted by that experience, I put everyone on antifungal, anti-mold, not just antifungal, anti-mold medication the first time I see them. I have them on the phone, and I already do this, right? And since that time, I had none, 0. I had one child with mucor that came, and again, nothing I could do about this. But that was unusual circumstance. But since that time, and I take care of, not just patients with dyskeratosis, but I take care of everyone with severe aplastic anemia and number of patients with Fanconi anemia, and it holds for all, these bone marrow failures. Hemorrhagic cystitis, unfortunately, is, a side effect of both the immune. It can be a part of the graft versus host disease, but it's also a side effect of some of the medications we use and the viruses. So that needs to be controlled. And then the last one that I'm going to mention, there are hundreds and hundreds of complications after transplant. It should not ever somehow suppress the thing that vast majority of the children and adults that we treat survive the transplant, and actually this opens up a future for them that they didn't have before. Okay, so it's successful, but there's a large number of complications that almost everybody has some, and some of them are life-threatening, and some of them are very severe. Veno-occlusive disease is a condition that affects lining of the vessels. And even though we find it typically and identify it in the liver, it actually affects everywhere, any organs that have vessels, which are all the organs of the body. And we now know, how to go after this, and the ultrasound that with Doppler that's shown on the other side showed you, how we sometimes are able to diagnose this fairly quickly. Okay, any questions about complications? That was my task as well this morning. No? Oh, good. You are also my hero. Yes?
My son had a lot of vascular bleeding.
Yes?
He's 5 years old. I don't need a microphone either.
Okay.
They had said when they did the liver biopsy that there was question that there might be mild VOD that might be causing the bleeding.
Yeah.
But I mean.
So bleeding is a part of veno-occlusive disease, because one of the things that happens is that the clotting factors that are made, some in the liver and some in the lining of the vessels, they are consumed by the injury to the vasculature. So the bleeding can be a part of veno-occlusive disease. And the liver biopsy, I obviously don't know the details, but the liver biopsy can show that there is a pressure put on the liver because of the veno-occlusive disease. Not necessarily, not telangiectasias, at least not to my knowledge. It probably is separate from veno-occlusive disease. Okay? Thank you. You're welcome. Any other questions? Please.
What do you do to prevent and treat veno-occlusive?
Oh, very, very good point. So the question was, what do we do to prevent and treat veno-occlusive disease? And a couple of things. First of all, we avoid some of the medications, that we know are related to this, and we limit the exposure to them. That's one. The second one is there are a couple of families here from Canada. Canada is great because for many reasons, but one of them is they did some things, you know, like 20 years before the medicine in the US, and one of them is called defibrotide. So defibrotide, you know, until about 3 years ago, I was not able to use at all in the US, even though it has been used in Canada for 15 or I think 20 years. So I used to get it from Canada, and this is one of these, you know, things when, again, you have to be, you know, stand up to misfortunes and failures. You have to sort of accept, you know, that things are stacked against you, because I have somebody who needs this defibrotide. The hospital, legally, I cannot get it, you know, in the US. So I have to, and it's entirely silly, you know, because the whole thing, you know, this is just basically a pure DNA. So you know how it's made, defibrotide? You take a placenta, you know, which is usually thrown to the, you know, biohazard bag. You put it in a blender, right? You push and then isolate the DNA. That's it, okay? All right, that's not really a rocket science. Anyway, these fragments of DNA are very helpful in picking up the reactive oxygen and reactive nitrogen species that are so damaging in the, to the vasculature of the vessels. Good? Okay, so bone marrow transplant, life-saving measure. It would never be used if it had not had so favorable effects. It would never be used if there were alternative measures. So anybody who comes to my clinic has, you know, this difficult decision to make. First of all, my job is not to make the decision at all. My job is to bring the best medical and human knowledge to your doorstep. And I can do that, again, because I've been lucky to be in a position to be that. I'm very quick to tell you, go somewhere else if this is something I don't do. I'm very quick in consulting my friends and colleagues like Dr. Bertuk, Dr. Savage, others. That's why we have the DCO. That's why we are communicating with each other. And use the knowledge that has been accumulated by somebody else elsewhere. But should we decide, and also I should say that exactly because I do bone marrow transplant, I know when you should not be considering that. So there are a number of people, you know, with dyskeratosis that, you know, see me as my colleagues, you know, every 6 months, every year. They don't need a transplant. But I know what needs to be done, and you covered this a little bit yesterday, you know, with regular bone marrow aspirations, counts, looking for things, so that when do you need the transplant? Yes, then we are the shop. You know, we know how to do that. Now, the recommendation can be strong, should be strong, but the decision is always yours. The decision is always, you know, do you accept high toxicity risks up front or not? Because that's almost always the case. And sometimes your decision making is going to be obviously forced by the fact that you have no other option. So when I explain it to my residents and fellows, I say bone marrow transplant in my clinic is only for people who have fatal disease. It has to take their lives, and no other options exist. Right? So we take this very, very seriously. This is not something that is just, you know, we offer it because we do it. It's the opposite. And the majority of people who, you know, come to this juncture say, what about gene therapy? What about drugs? How about this research? Well, it's all good. You know, it should be supported, as I think, you know, many times repeated. That's where the new discoveries will come from. But it's not going to be good. It's not going to be enough. It's not going to be in time for somebody who has bone marrow failure today. So 50,000 people every year, more than 50,000 every year, get bone marrow transplants around the globe. This is very standard of care. So how does this fit into dyskeratosis? So the most knowledgeable and the most profound influence, you know, in the whole field has been, I think, by the team of Dr. Savage, who has really put the complex biology that happens on the end of the telomeres, on the end of the chromosomes together, and has done some groundbreaking work in discovering the players, the bits and pieces that have to fit together and how they relate to genetic disease. It is also important, and Dr. Bertek and others have done tremendous work on this, to see how the telomere biology fits into other diseases as well, because it is almost certainly a continuum that goes across, many other things. And some of them are part of dyskeratosis and some of them are not. The ones that are part of this is the fibrosis of the lung, the conditions that can affect the liver, and most likely some immune and inflammatory things as well. This is the classic, and I think the standard. One of you has published, that qPCRs should not be used instead of this for diagnosis. Absolutely true. This again, is the flow cytometry that shows the ends of the telomeres being below the first percentile in multiple populations of the marrow. Remember at the beginning I showed the different, lymphocytes and myeloid cells. That is almost diagnostic of Dyskeratosis congenita. And when you are faced with a bone marrow that's on the top, which is a healthy one, this is what a bone marrow, if I had a bone marrow biopsy, most likely would look like. It's packed with cells. And you compare it to someone who has the one on the bottom, which is basically an empty marrow, you clearly see that you go from the beautiful green tree that resembles the healthy hematopoiesis to something like this. And then what? Right? Then you have very short window of opportunity to intervene before one of these little leaves on this tree will misbehave and produce either myelodysplastic syndrome or leukemia, or the load of the transfusions is going to compromise liver or heart, or just you cannot keep up with the infections and with the bleeding. So then you need to intervene, and fortunately, the bone marrow transplant is the way to do it. Before, it's almost silly to say that, but before the bone marrow transplant, there were no options. So I am profoundly grateful to the group at NIH, Dr. Savage again, that they approached us about 10 years ago and said, well, you deal with bone marrow failures. We have seen that in dyskeratosis, there are some transplants, but they don't seem to have been going very well. And can something else be done? And because we have had this large laboratory enterprise, large clinical experience with other things, we put together a recipe, literally, conditioning recipe that we felt based on the experience from other fields, and also on looking seriously at the dismal outcome of the transplants before that time, that we have put together this one, and has the three parts that I mentioned in the conditioning. Has the immune conditioning here. This one is called CAMPATH. It's not like the ATG, but it's similar to this in effect. It is a very low dose of cyclophosphamide, fludarabine, which is an immunosuppressive medication, and a low dose of total body irradiation. And when we started this, we published, I think there were only 7, but we have 10 more. There are 17, which must be one of the largest groups in the world. People transplanted on this. We went from what at the beginning was a very disappointing way of getting the engraftment. So this shows you how quickly after transplant the neutrophils, the first responders in the infection fighting, how quickly they occur. And I said that the infections are the most dramatic complication that we see? Well, the neutrophils are really the first cells that are going to help you fight these infections. So the shorter the period to the time that you have the neutrophils, the better for the outcome after the transplant. So with the median day of 13 days, give or take, 2 weeks, you had very successful neutrophil recovery. So you saw the green tree, you saw the tree in winter, and this is, really where, these new cells, you put them on the tree, and now they can start doing what they are supposed to do, which is to provide for all the infection fighting, all the blood clotting, all the oxygen carrying in the body. And the survival has been 88%. This is, no death is acceptable. That's absolutely, ma'am. Oh, this is a 2 year after transplant. 2 years. 2 years. So we look at 1 and 2, but this is 2. I know it goes to 4, but that's really where the bottom is. And so if you look at the whole spectrum, I have patients that I transplant that have 5% survival. These are some kids and adults with relapsed leukemia, for example. And these patients and their parents, they want to do it. They know that it's 0 versus 5. In others, we have 20% survival. In somebody who has the least complicated transplant that exists on the books, which is not dyskeratosis, but it's severe aplastic anemia, it's still 1 out of 10 will not be able to live through the transplant or consequences of this. So 90% is really, the best we can do with what we have today. Okay? So 88% is close to that. Ma'am.
Have you segmented that into siblings versus unrelated donors?
Very good question. So in this protocol, I used only well-matched unrelated donors. So this would be 8 of 8 or 7 of 8. This is the HLA matching, or the matched sibling donors. We had approximately the same half and half of matched sibling and unrelated donors, and we did not see any difference between the two groups. Very good question. Yes,
so
good.
Does that tell us that the HLA matching process is incomplete? There's still things to...
Oh, absolutely. So it tells you 2 things, I think, at least 2. One is that having unrelated donor is fine, because it really, we have seen the same thing in severe aplastic anemia. Actually, in the United Kingdom, they were first to recognize this. We were sort of adopting that, that they said, you can use any matched unrelated donor. And the second thing is we have, the HLA mapping is entirely incomplete, because what we are doing is we are taking a very large part of the chromosome 6, and we don't look at every single gene there. We look only at signposts. And if there are 3 on each chromosome, we call it 6 out of 6. If there are 4, we call it 8 out of 8, right? And we have up to 6, and we call it 12 out of 12. But that assumes what's called in genetics linkage disequilibrium, which basically means that the whole bit is being inherited together, which sometimes is and sometimes is not. So it's imperfect in that way. And the other thing that's imperfect is that there are many what we call minor antigens. Some of them are on the Y chromosome, on the male chromosome. Some of them are on other chromosomes that are totally unmatched. And we are very interested, and that's why Minnesota is a very good place to be for transplant, because we are now adopting from our other programs in leukemia especially, typing, for example, for NK cells. These are called natural killer cells. They are lymphocytes that are, again, one of the first responders in infections. And there, we now have, for the first time, ability to match or mismatch sometimes with the receptors that these other lymphocytes have. So we are expanding this all the time. But you are correct. It's imperfect. Very good question. Yes, ma'am.
If you have 88% survival at 2 years, do you
Ma'am.
have any estimate of the number of people who have significant morbidity such that their quality of life is significantly affected?
Very good question. Very good question. I would say that if you, so good question, difficult answer. Because in contrast to, say, childhood leukemia, you deal with the primary disease. So dyskeratosis obviously is a multisystemic systemic disorder. So there's sometimes a question, what has been the natural progression of the disease in the systems that are not hematopoietic and cannot be possibly affected by transplant, and what is the consequence of bone marrow transplant itself. What I have started using is what I call secondary natural history. So there are some kids in this and other genetic disorders that I treat that you have a community, you have a large group of individuals that would never be alive previously. So the natural history that has been described for them doesn't really apply because they survived something that would not be survivable before. In this sense, you don't really know. You don't know what other things can be uncovered by being able to live through the critical bottleneck, such as the bone marrow failure. Make sense? So there you, and that's, there are many reasons why I come to this camp, but this is one of them, that I learned from you more than you know. When you ask me questions, I learn from this every single time. I write it down, think about this, I try to extend it, because you have access to information I don't. You know things, that are outside of what I can even consider being important, right? And for that I am, forever grateful. I had, I have to say this, it's FA, so I come here for 2 days. FA is the other one on the off year. So I am at this, doing similar discussion, for FA, and then talking to the parents. And every single one says, I say, what is the worst thing after transplant? And I'm thinking, they're going to say infections or he's tired. No, abdominal pain. Abdominal pain I didn't ever think about in my clinic. They said it. I'm sure they said it. But it just didn't figure in my priority list as high. So since that time, I pay extra attention and try to design things in FA now to go after the abdominal pain, because that was so important for people like you with different diseases. Okay, based on what especially Dr. Berturk and others have put forth, really the prominence of the injury to the lung. So we have, even with the low-dose TBI, total body irradiation we use, we shield the lung. But still, it is low dose, but still it's a radiation. So we said after, having done this successfully for, I told you 17, we said we can drop the TBI. And in fact, what Dr. Agarwal is going to talk to you this afternoon about is our new program, that, again, I like teams. I like people working together. So what we have done is, we have a team of multiple institutions that will do the same trial, and it will have no TBI. It will be actually simplified, and that's going to be the new standard in the field. That's how we're going to learn quickly. Still good? I have about 5 minutes. Am I good? I'm finishing up. So this is where it's going. So as a transplanter, my job is to get transplant off the books, okay? In my lifetime, I want a transplant not to be used, okay? So this is how we're going to do it. For genetic disorders, for leukemia, I have a different plan. But for genetic disorders, we are just going to, again, learn from nature. We're going to go to the genetic defects that originated the whole problem. We will use, as is shown in this diagram, the cells from the people that typically would get bone marrow transplant, and we will genetically correct, as we have done on both sides of the Atlantic. I am in these gene therapy trials that work on immune deficiencies, on Fanconi anemia, other problems, and we will do the same thing for dyskeratosis, okay? That's a huge part of what my lab is working on. These are the people. This is your safety net. This is where, these doctors are the ones that have your safety in mind all the time. And again, they are creating, the new starting point for your loved ones. Okay, thank you.